Good evening, everyone. Welcome to today's webinar, Clinical Utilization of ECMO in COVID-19 Pandemic, What a Respiratory Therapist Should Know. My name is Gokul Krishna and I will be the moderator for today's session. I'm pleased to introduce today's speaker, Mr. Jithin K Sreedharan, our current General Secretary of IARC. Sir is currently working as lecturer and also as Superintendent of Clinical and Laboratory Affairs in Prince Sultan College of Health Sciences, Saudi Arabia. Before starting the session, I have few instructions for all the participants. Today's webinar will be available on demand after the live session and is accessible through the IRC YouTube channel. Before next, we will love to hear from you during today's presentation. If you have any questions for our speaker, please feel free to send your questions in the chat session. We will be addressing it at the end of the discussion, at the end of the session during the discussion time. We request everyone to mute your mics and videos for the smooth functioning of the webinar. And last, we encourage everyone to fill the feedback form. It is very important to improve our quality of sessions with your feedbacks. So please do the same. And also, if you are sharing these webinars through your social media accounts, please feel free to tag IARC and you can use the hashtag IARC webinar. So without any further ado, I welcome Jithin sir to start the session.
Very good evening to all. Greetings from Prince Sultan Military College of Health Sciences, Saudi Arabia. And on behalf of IARC, I welcome you all for this webinar. We all know that coronavirus infected tens of thousands of people in China and has spread quickly around the world. We RTs are the frontline responders in fighting this pandemic. Our expertise and knowledge is extremely crucial, especially when 15 to 30% of the infected develop ARDS. As per the WHO's interim guidelines, ECMO is considered as one of the life-saving measures. The preparedness is important in view of high transmission rate and respiratory-related mortality. This makes us all alert because ECMO is within the scope of practice of respiratory therapist. Today's objective, I will be able to introduce you ECMO and ECMO extracorporeal life support, the types and equipment and the accessories used. I'll be going in depth about the indications with a focus on the respiratory point of view. We'll be trying to explore the limitations and contraindications, especially during the time when we deal with such pandemics. We will go through a brief about the evidence currently available, the lessons learned from similar outbreaks and correlations. I'll be able to explain to you the multidisciplinary team approach for establishing an ECMO program, where I'll be focusing the role of a respiratory therapist. Finally, definitely most of the participants today, they will ask me a question: how can I be trained extensively on ECMO and how can I be certified? I'll try to give you some insight on this as well. I understand from the moderator today, the participants of today's webinar are from diverse background. Few have extensive experience, but many have limited exposures. I will try to do my best to do justice to everyone. Pardon your attention. Let me give the introduction in a very short video. Let's watch.
Saving a life is no easy task. Options for treatment vary based on the severity of injury, the prior health of the patient, the experience of the medical team, and the resources available.
I hope there is a problem with the video due to the streaming delay. So ECMO is I will try to explain it very quickly. Okay, ECMO is a life-saving procedure used in intensive care medicine to provide both respiratory and cardiac support for patients whose heart and lung functions are compromised. It is also known as extracorporeal life support, or ECLS. It is a form of modified cardiopulmonary bypass in which venous blood is removed from the body and pumped through an artificial membrane, lung, in patients who have refractory hypoxemia or cardiac failure. Oxygen will be added, carbon dioxide will be removed, and the blood is returned to the patient, either via another vein or to provide respiratory support, or a major artery to provide circulatory support. ECMO is a resource intensive. Remember that it is a very highly resource intensive and highly specialized and expensive form of life support, which with the potential of significant complications, in particular hemorrhage and nosocomial infections. It all started in 1970s, ECMO. I'm talking about ECMO in particular. I'm not talking in the history of the cardiopulmonary bypass. It started in 1970s when Baffes and his colleagues reported the successful use of extracorporeal membrane oxygenation as a support in infants with congenital heart defects after undergoing a cardiac surgery. Long-term ECMO as support for severe respiratory failure was first successfully used in 1972 in an adult patient with post-traumatic respiratory failure. It lasted just only for 5 hours. This is the image of that ECMO which was used in 1972 on a traumatic patient. In 1975, it is reported the first successful use of ECMO in neonatal case with severe respiratory distress syndrome. That patient's name was Esperanza. This was the first on the left side, what you're seeing on the screen. That picture is the neonatal period when the child was undergoing ECMO on first day of his birth or her birth. And on the right side, you're seeing that same lady is on a 21-year-old at the time of age. Subsequently, in 1980s, this veno-arterial mode was changed to veno-venous mode. But only few centers persisted with the technology because bleeding and poor outcomes were very common. Later on, this trial came. This was the largest clinical trial to investigate the efficacy of early use of ECMO in patients with ARDS. This CSER trial in 2006 defined the appropriate use of extracorporeal life support for adults with severe, potentially reversible respiratory failure. Believe me, the results of CSER trial were really encouraging, but not all the patients in the control group received the ECMO. The use of mechanical ventilation in the control group lacked standardization, which was one of the major limitations in this particular trial. From there, we will go to the types of ECMO in very, very brief. In this animation, you will understand simply how the veno-arterial, veno-venous types are working. Veno-arterial ECMO was the first introduced one, where the heart as well as the lungs need to rest and heal. So you will go for a complete bypass. In veno-venous, the heart will be functioning very well, only the lungs need to rest and heal. There are other advanced type of ECMO is available. They are called extracorporeal CO2 removal, ECC2CO2R. It is also pronounced as ECOR. In this technology, oxygenation is provided by slow ventilation of the native lungs. That means you have to continue with your mechanical ventilation. Okay, and The CO2 will be accomplished by the ECMO circuit. That the external circulation will try to remove the entire CO2 or excessive CO2, thereby maintaining the pH. The fourth type is arteriovenous ECMO. It is also called as novel lung. The gas exchange driven by systemic arterial flow through an extracorporeal membrane. There, you will take off the blood from the heart or from the venous, from the artery. All the other types are taking the blood from the venous side. Here, it is taken away to the machine from the arterial side. Okay, and adding more oxygen, removing carbon dioxide, and pushing back to the venous system. Okay, in this case, you don't need an extra pressure or external device to circulate. So the circulatory device is actually bypassed. This is more applicable in neonatal patients where the heart rate and the blood pressure is very low. This picture typically focus on VV ECMO. In my lecture today, I focus on VV ECMO, which can provide complete pulmonary support, allowing for adequate oxygenation and carbon dioxide removal without exposing the patient to potential ventilator-associated lung injuries, which is associated with conventional mechanical ventilation techniques. That's what we may require at this outbreak. This picture typically two-site veno-venous setup with right femoral venous drainage and a right internal jugular venous return. Excuse me, I have some disturbance here. Let me just, extremely sorry, kindly pardon me. Circuit, you can see typical two-site veno-venous setup with right femoral venous drainage and right internal jugular venous return on the top. Deoxygenated blood is withdrawn from the patient and pumped through the membrane lung, where allow the passage of gas, typically 100% oxygen, delivered from a blender. The blender also can be seen on the side. This is the oxygenator, and that's the return of blood to the jugular vein. Simultaneously, the oxygen leaves these fibers. A heat exchanger with the oxygenator allows control of body temperature. Oxygenated and decarboxylated blood is seen exiting. You can see the color changing in the circuit after the oxygenator. I hope you can observe this change. And under positive pressure, it will be reinfused to the patient through the internal jugular vein cannula. When it comes to the machineries and the accessories, I have again this animation which will clearly explain to you the blood is being withdrawn and which will be circulating through a pump, and a bladder will be collected before the pump to avoid the negative pressure. And from there, it will go into the oxygenator where the oxygen will be provided and will pass through a heat exchanger where it will maintain the body temperature. These two animated videos will explain to you how the machine is actually working. And if I go to this machine and accessory, you can see the evolution of this machine from a full room occupied machine setup to a very handy and portable machine where you can see the lower one. It's a Mackay device. It is very handy and portable, and it came into this particular advanced stage now. When we talk about the circuit, it is a lengthy one. It is made up of PVC. The ECMO circuits can vary from simple to complex. It may include a variety of blood flow and pressure monitors, continuous oxyhemoglobin saturation monitors, circuit access sites, and a bridge connecting the venous access and arterial infusion limb of the circuit. It is made up of typically PVC, as I mentioned, which has many segments and of different inner diameters depending on the patient size. The shortest amount of tubing necessary to allow rest resistance to flow and to decrease the circuit volume especially in neonatal patients will enhance the efficacy of the circulation. Some circuits contain especially a heparin-based coating. There are a lot of infusion ports. You can see the arrows. These infusion ports are actually used for sampling arterial blood gas sampling, or connecting to the blood pressure monitors. You wanted to infuse blood, you wanted to connect it to the heater, additional fluid supply. All those things can be connected to this infusion ports. The next important accessory is, or the part of the device is oxygenator. It is also called as a membrane oxygenator. It is a device used to add oxygen to and remove the carbon dioxide. Whether it is called only oxygenator, but the function is not only oxygenation, it is also going to remove the carbon dioxide from the blood. It consists of a gas permeable membrane in between, the same like that of a filter paper that you have seen in the HME filters. But actually the component of manufactured is entirely different. I'm just giving it just to have an idea about this. This membrane is separating the blood and the gas flows in the CPT circuit, where the oxygen will be diffusing into the gas side into the blood, and the carbon dioxide diffuses from the blood into the gas for disposal. That's how it works actually. The next most important part is a pump. The pump has, it's an essential component of the ECMO circuit. It is responsible for circulating the blood through the circuit and the membrane lung. It should be capable of providing typically 75 to 150 ml per minute within the safe range of pressures to avoid hemolysis. Commonly, there are two types of pumps available. We are seeing roller type and a centrifugal type. The first one, what you're seeing in the red color, is the roller pump. Another one is the centrifugal. The roller pump doesn't have, both has its own advantages and disadvantages. The first one, the roller pump has no contact with the blood. That's the most important advantage. But whereas the centrifugal one has, the blood, the damage of the blood cells on all is there. There are a lot of advantages, pros and cons of these two devices. But I'm not covering in depth into that aspect because of the time constraint. Next one is about the cannula. Okay, where there are usually three ways for accessing the major vessels for ECMO. Okay, mainly central cannulation. It can be surgical. Again, surgical peripheral cannulation. Another one can be a percutaneous cannulation. The internal jugular veins, femoral veins, and the right atrium mostly opted for venous circulation. Okay, whereas for arterial cannulation, carotid arteries or femoral arteries and the aorta respectively can be used. Okay, for VV ECMO, venous cannulae are usually placed in the right or left common femoral vein for the drainage purpose, and the right internal jugular vein for infusion. This is the most common site of access. Okay, there are also advanced type of cannulas available, a double lumen cannula, where it has two openings, but one insertion site is enough. It can accommodate 4 to 5 liters per minute blood flow, as shown in the picture. The shape will be like this, and the drainage and infusion ports have been engineered to minimize recirculation as well. Additional facilities required for having an ECMO is, a dedicated room and a space, a device for monitoring the level of anticoagulation, like ACT or other with appropriate supplies should be at the bedside available. Backup components of ECMO system and supplies, because most of these equipments and parts that you're using is disposable ones. So you need to have enough backup to replace if there is a requirement. Adequate lighting to support any surgical interventions, because if there is any bleeding or any such kind of things may be requiring a frequent change or switching as well. Surgical instruments set for revision of cannula or exploration of the bleeding complications. Support facilities, it's very, very important. You should have a blood gas machine all the time available to run repeatedly the blood gas, to know the blood gas values repeatedly, because it will act very quickly. The changes in the blood chemistry will change very quickly because of the external circulation. A laboratory or blood chemistry and hematological testing. Blood bank should be open because you may require more and more blood products over the time. Radiographic support, including ultrasound and CT scan, cardiovascular operating room facilities with CPB capabilities if there is an emergency need for cannulation or going into full cardiopulmonary bypass. VV ECMO is more efficient at removing CO2 from the blood than delivering oxygen. This is the first thing we all must understand. The amount of carbon dioxide removal depends on the ECMO flow rate. How much is the flow rate for the ECMO that you're maintaining relative to the patient cardiac output? You need to have a definite cardiac output, because the heart is not at rest, it is working. Only the lung is at rest. The cardiac output, and depends on the oxygen flow rate, which is also called as sweep gas to the oxygenator, the amount of oxygen that you are giving to the oxygenator. This is also important in veno-venous circulation. Arterial oxygen is determined by the relationship between the ECMO pump flow and the patient's cardiac output. If the ECMO pump flow is low compared to the patient cardiac output, the arterial oxygen will be also low. Okay, that is the relation. If you try to increase the ECMO pump flow, which will increase the O2 in the mixed venous circulation and therefore increase in the arterial oxygenation. Okay, I'll be focusing to the veno-venous type. As I mentioned in the beginning itself, there are indications differently on veno-arterial and veno-venous. Let me focus to the veno-venous indications. In ARDS, we may require veno-venous. Bilateral extensive pneumonia is a typical indication. Meconium aspiration in neonates, aspiration pneumonitis, massive chest contusion after trauma, smoke inhalation injury, and intractable status asthmaticus. I will stress on this point because very recently, in a 6-month time, one of our faculty went to the casualty and got arrested there. Not arrested. He was the emergency unit crews were not able to ventilate him. So this was a suspicion of a intractable status asthmaticus. So I focus on this one, and luckily the expert RTs and the emergency physician and the nurses, they identified immediately the need of going into advanced measures, and he is now very well. He is doing extremely well in our setup, and he is still continuing in his functions. There are criteria for lung needing ECMO. The first one is the Murray score. Okay, you calculate the Murray score, and as per the ELSO guidelines, okay, they advise that if your Murray score is greater than 3, you must consider putting the patient on ECMO in a correct clinical settings. They also suggest that if the patients are above 2 of Murray score, you should be considered to transfer this patient to the ECMO capable center or a facility who can handle the ECMO patient. Okay, it is also important to consider all the other patient factors as well as contraindication and the risk of ECMO must be considered before you opt for ECMO. This is also called as a risk to benefit ratio. This must be calculated before you select the patient to go on ECMO. There are re-emerging indications, extracorporeal carbon dioxide removal, which is a technique related to ECMO in which lower blood flow rates are used with primary intention of carbon dioxide removal. Gagnoni and his colleagues referred this method as lung rest. Maybe you have seen this in the references of ARDS management. We all know that the low volume, low pressure ventilation strategy has been shown to improve survival rates. Most of the occasions, we RTs have to sacrifice the lung protective strategies as a result of low compliance and unacceptable pH levels. By directly removing the carbon dioxide from the blood, the ECMO could permit the lung protective ventilation in these patients by maintaining pH and pH at a low tidal volumes. There are also potential benefits of reducing and eliminating the need of invasive mechanical ventilation, such as patients who undergo transplant, etc., cannot be missed. Also, at this point, I just wanted to mention that the prevention of valley and the need for sedation and all those things should be minimized for such patients. Also, there are ECMO has been reported to be used in acute exacerbations of COPD. Which is a strategy which could significantly alter the current management paradigm. You may have seen this in the references as well. Just I wanted to mention it. Look at this X-rays. This was the one of the case out of 9 total cases reported from China. From China, I hope you all are familiar with chest X-ray. These I want to relate it with something in the upcoming slides. That's why I'm mentioning this one. These radiographic images shows a single nodular lesion. You can see in the arrow, the chest X-ray shows single nodular consolidation, which was a mild case. Okay. The second patient is and this X-ray is showing baseline, patchy ground glass opacities on the right upper and lower lung zones, and a patchy consolidation on the left middle and lower lung zones. Hope you can see this in the chest X-ray. And you can see the coronal chest CT image show a confluent pure ground glass opacities involving both the lungs. The third patient shows a multifocal patchy peripheral consolidation bilaterally, except the upper zone of the left lung. The coronal CT also shows a confluence, mixed ground glass opacities and consolidative lesions in the peripheral bilateral lungs. And also you can see a discrete patchy consolidation on the left upper zone in this patient. Okay. Look at this slide. This was a specimen taken from the middle lobe resection of a COVID patient, and it was reported in the Journal of Oncologic Medicine from Japan, if I remember correctly. Which revealed there is typically evident alveolar damage and including alveolar edema and proteinaceous exudates in this specimen. You can see the panel A is showing it typically there is a damage and alveolar edema. Whereas in panel B, you can see the fibrin clusters mixed with the mononuclear inflammatory cells and in the air spaces. In panel C, you can see a typical interstitial thickening, which indicate an ongoing reparative process. And panel D is showing a suspected viral inclusions with these particular cells. Okay. In summary of these 4 slides, these 3 out of 9 patients were confirmed to have parenchymal abnormalities related to COVID-19 pneumonia. Indeed, this shows radiological similarities to SARS and MERS pneumonia. As you know, they were high susceptible to ventilator-induced lung injury, and subsequently a high mortality rate is associated with such kind of patients. Okay. So what are the conventional methods that we follow to treat such weak lungs? Okay, we will be starting with supplemental oxygen. If SpO2 is less than 90%, we'll try to maintain it above 96%. Sometimes we will think about nasal cannula and high flow nasal cannula or non-invasive ventilation. But in this cases, COVID-19 cases, this is less suggestive. Remember, viral transmission through the exhaled air should be considered while using these techniques. Okay. Close monitoring for the worsening of respiratory status and early intubation, if worsening occurs, is also recommended. The adults receiving mechanical ventilation who have ARDS use always low volume and low pressure, low volume ventilation strategy. We will also consider sometimes associated with higher PEEP and deep sedation. This is the conventional method that we follow. In next level, we will think about 12 to 16 hours of proning, but considering its associated risk factors of exposure to the healthcare providers are very, very high, because we need 4 to 8 individuals to manipulate this patient during the proning procedure. Okay, so this has a high risk of transmission. For optimizing ventilation, we sometimes think about inhaled nitric oxide that is also suggested in the WHO guidelines. We will also follow the negative fluid management, dialysis to maintain the pH, also considered in certain cases. Now coming to the ECMO. Okay, the role of ECMO in the management of COVID-19 is typically unclear at this point. It has been used in some patients with COVID-19 in China, but the detailed information is not available at all. The available evidence from similar patient population suggests that carefully selected patients with ARDS who do not benefit from conventional treatment might be successfully supported with veno-venous ECMO. Okay, so it is similar to that of the previous evidences that we have. Use of veno-venous circulation for ECMO in a referral to ECMO center is usually suggested. The WHO interim guidelines for the management of suspected COVID-19 also recommend administering veno-venous to eligible patients with COVID-19, but the recommendation is weak. It's not very strong recommendation at present. Let's go to some evidence, what has been reported. Okay, the result of first 2 randomized controlled trials 20 years ago on ECMO were really disappointing. The early evidence suggests that use of ECMO in most severe cases of ARDS is really associated with reduced mortality. The EOLIA trial, which is the most popular one and the recently came one, which published in 2018 in the New England Journal, showed no significant benefit of early ECMO. So you cannot think that before you go into a severe stage, you think about putting an ECMO, as compared with the strategy of conventional mechanical ventilation. The frequency of complication also did not differ significantly between the groups in this study, okay, in this trial. Whereas there were more bleeding events leading to transfusion in the ECMO group than in the control group, as well as more cases in cases of severe thrombocytopenia, ischemic stroke are also observed. The trial was terminated very early because of its other administrative concerns. There was, however, a non-statistically significant at large reduction in mortality with ECMO has been noted. When we go into the influenza experience, the evidence from that says that, most of you remember that in 2009, novel H1N1 virus led to the worldwide pandemic. It began in northern hemisphere and then spread down to Australia and New Zealand, causing an approximately 8-fold greater number of confirmed cases all over the different countries and its population. The spread of this virus to Australia and New Zealand was also associated with a large number of patients admitted to the intensive care units across these 2 countries. Okay. The patients usually presented with or developed severe ARDS or similar syndromes as that of the corona patients. That's how I'm relating it with. In some severe cases, mostly in the young population of ECMO, was commenced for the treatment of refractory hypoxemia and hypercapnia, or as a combination of both, which occurred despite mechanical ventilation and rescue therapy for ARDS. The results showed 58 55 to 78 percentage of recovery, and had been weaned off from ECMO, and nearly 50 percentage had survived to hospital and discharged home. Okay, now the evidence from MERS. Okay, this is more interestingly shown, which is we all have gone through this era of treating the patient while there was a MERS-CoV outbreak. Compared to the control group in this study actually from Saudi Arabia, compared to the control group, the ECMO group had significantly lower mortality. But they also reported the use of significantly lower use of inotropes and better oxygenation index with a PaO2, a higher PaO2 and FaO2 ratio. They also reported, a longer ICU stay in these patients. Now coming to ECMO in COVID, what is the evidence? The role of ECMO in the management of COVID-19 is unclear at the point. I'm stressing on to this point, it is unclear. Anytime you may come up with some more evidences for this one. Support with ECMO is for the most critically ill patient. Okay, the extensive resources are required to provide this therapy. This is the one what is being limiting the people to use it. It has been used in some patients with COVID-19 in China, but detailed information is unavailable. ECMO may have a significant role in the management of some patients with COVID-19. However, much about this virus itself is not known at this present. This is the most crazy thing, including the natural history, incidence of complications, viral persistence, or the prognosis of in different subset of patients. This uncertainty might be compared to the emergence of influenza H1N1 in 2009, when it was initially unclear and the role of ECMO should be how it should be used. However, a lot of details we need to get regarding this particular virus. What is the natural history, whether the virus will persist, and what are the precautions that you have to take for the personnel who are taking care of ECMO machines in the isolation rooms. What is the adherence of this virus to the tubings that you are using, how the patients might use from the treatment, and a lot of information we need to come up. Okay, this need extensive research. Also, in one of the article I read, it was not formally published anywhere, but one of the articles said, coronavirus causes death after infection of the lung. Okay, but does it affect the alveoli or upper or lower airways? This is a big question. Also, they are questioning how does it affect the respiratory muscles? How does it affect the oxygen exchange and the oxygen transport or binding? Or does it cause any bleeding to the alveoli itself? So in these cases, ECMO will not be useful at all because the pathophysiology itself is prohibiting you to use it. Okay, so these are some of the news which comes in unofficial platforms, but we really wanted to get an authenticated reports. Are not willing to completely rely on such news which is coming in the media, or especially in the social media. In the past, the major goal of ECMO for respiratory failure was to maintain adequate oxygenation. This we all know that. Okay, the hypothesis was the patient with severe hypoxemia were dying of tissue hypoxia, hence increasing arterial oxygenation and using ECMO would improve the survival. But in the past few decades, it has become clear that the major cause of mortality in patients with severe respiratory failure is iatrogenic injury. It is due to ventilator support itself. It's referred to us that it is VILI, ventilator-induced lung injury. ECMO, if we are providing adequate gas exchange, allows the RTs to decrease the respiratory therapists to decrease the intensity of mechanical ventilation. It will in turn decrease the incidence of VILI. You can see in this, one figure, all the indications and physiological mechanism to benefit from ECMO. Based on a large body of evidence from patients with ARDS, this significant decrease in VILI thought to be more important to clinical outcomes in most patients with ARDS receiving ECMO. as compared with the patients those who are not receiving the ECMO. Okay, let's go and see what is the contraindication in terms of absolute contraindication and relative contraindication. Definitely, absolute contraindication includes the selection of patient itself. It is irreversible cardiac, pulmonary disease, metastatic malignancy, significant brain injury, current intracranial hemorrhage, major pharmacological immunosuppression with an absolute neutrophil count of less than 400. Whereas relative contraindication includes the age itself, more than 65 to 70 years, considering the increasing age, which is common in all the ECMO selection criteria. It's not only for COVID patients. Another significant contraindication: if you are continuing the ventilation for more than 7 to 10 days, do not opt for ECMO. Maybe you are already crossed the stage. Where you may be also tried for more than 90% FiO2 with a plateau pressure of more than 30. Multi-trauma with high risk of bleeding also are relatively contraindicated for such patients. Now coming to complication, doctors already warned about using ECMO on COVID in patients due to lymphopenia. I'm not very, this is still again, it is not published in a very reliable journal. It is just news which I collected from the media. Other complications, definite complications are hemorrhage, thrombosis, hemolysis, infections. Mechanical complications include clots in the circuit, oxygenator failures, pulmonary embolus. All those things are common complications in ECMO. There are certain limitations with apparent contagiousness of this virus and the relatively high number of patients who require intensive care, which we are anticipating in future. This may prove very resource consumptive. It is not going to be handled as easy as you are doing it in a controlled atmosphere. Lack of ECMO consoles or disposable equipments we can expect, because most of these equipments are exported from China. We are facing a severe issue in this regards. Suitability of trained staff, isolation rooms with the requisite infrastructure, because you need to isolate the patient. You cannot take the patient into the general ICU and ventilate along with other patients, or do the ECMO with other patients. There is also a huge lack of regulation and centralization. The regulations are only from ELSO. There is not much regulations on a country base or a regional base. Utilization is not available. In India, there is the ECMO Society of India. I think they are providing some regulations, and they have a flying squad as well for providing support, but their service will be limited at this point when there is a huge requirement. They cannot fly down to all the places where they need the ECMO support. And training at this time, it is not a suitable time to train the people as well. So we must know the limitations very well before we elect any patient for ECMO. As you think about initiating ECMO, you must also think about weaning the ECMO. I'm sure most of us are dealing with this stage of ECMO, whichever RTs are now using or experiencing the ECMO treatment in their ICUs, not in the pandemic, earlier times. They are closely involved with the ECMO team at the phase when you start weaning, because there you are thinking about switching him to a conventional ventilation strategy and thinking of taking off the ECMO or liberation from ECMO. This weaning focus, as I showed in the picture, should focus on the balance between the natural and the membrane lung. So you have to go on ratio by ratio. For patients with respiratory failure, this improvement in radiographic appearance you need to focus on. Sometimes the pulmonary compliance and arterial oxygen saturation And if you are getting all these things together in a better way, you may be able to liberate the patient from ECMO. But all the thing that you need is you need to take multiple trials on the patient, okay, for whether the ECMO can be liberated permanently or not. This we how do we do this is like, you can take off the swapped gas. I mean, hope you remember that I told you we are injecting the gas into the oxygenator. There you have to go on lower percentages and you stop it, okay. You have to stop it permanently, but still the circulation will be on. So you can manage with the ventilator and you decide what should be the ventilator setting the moment you take him off from the ECMO. So this time is the window period for you to decide what is the ideal ventilator settings, and you are giving the patient for a chance system, the lungs a chance for maintaining his own, capabilities. So if he is maintaining reasonably well, you will be able to wean him off from the ECMO. You know this very well. A better clinical outcome which can be achieved in patients treated with ECMO with a well coordinated and multidisciplinary team specialized in ECMO, which can consist of physicians, nurses, perfusionists, RTs, and some other technicians, anesthesia technicians, physician assistants, a lot of team involvement, to smoothly handle this situation. They all should be explained about the pathophysiology, and they should understand the pathophysiology and the mechanism of ECMO. Okay, we as a RT, we are capable of doing this one. In a typical practical aspect, okay, the clinical settings of such a team effort will prevent the technical error. Also it will provide a better treatment strategy. This will also help us to document and record these strategies for further clinical research and for the reporting as well. The available studies, you can see it on the graph, showed a significant rise in survivors after the establishment of ECMO team, with an obvious and concurrent rise in the total number of ECMO cases. To make up an ECMO team, it really varies on across institutions. Just importantly, all members in the team, this is my message for them, regardless of their experiences, education, training, degrees, and titles, need to have respect and trust and place value on all aspects of contribution to all the members. In this particular slide, I'm showing a logo. This is ELSO. Okay, ELSO guidelines. ELSO is the international organization who maintains a registry for ECMO cases and provide guidelines for establishing ECMO and extracorporeal life support measures. As they outlined in this guidelines for setting up a center for ECMO, the institutional requirements need to effectively use of for the effective use of ECMO. RTs are an integral part. I just took a screenshot of their guidelines. They say in the clause number 3 that ECMO coordinator may be an experienced neonatal pediatric or adult intensive care registered nurse or a registered escalator. This is applicable not only in the US, it is also applicable for us. Most of our curriculum covers one portion of ECMO at the end. And our textbooks, our reference books, all these things are having a portion of ECMO. Only thing what is lacking is our own initiative to get into this and start practicing ECMO. And also they mentioned in the in the sub clause that a successful completion of a degree in the respiratory therapy program, they are eligible to go extensive training in ECMO management. According to AARC's position statement, an ECMO specialist should be able to or capable of or responsible for maintenance of normal acid-base balance, oxygenation, and ventilation, which we are regularly doing. When it comes to ECMO, the technique is going to be different, but still your target is same. Your objective is same. Where you will be doing additionally 3 responsibilities they are administering the blood. Okay, for that, you need to know the technique, and you have the nurse to assist you for administration of blood. And you should be the one guiding or getting the order for adequate volume, because you are the one who is maintaining the circulation. You should know when it is going down, when it is going up. So you need to maintain it. You need to have a medication delivery idea, because you don't have other IV lines available. Sometimes you may have, you can inject your medicines to the circulation, because it's directly going into the circulation. That's what the infusion ports are required too. Maintenance of appropriate anticoagulation, you need to check the ACT, as I mentioned, in a frequent interval. So, and also the blood gas values in a very frequent manner. The RT's education itself provide extensive training in acid-base balance, number one, oxygenation and oxygen delivery, number two, ventilation, of course. We are going through extensive training on cardiopulmonary anatomy, physiology, and pathophysiology, right? I hope you all agree with that. We also have got enough training on, troubleshooting. That word itself is very precious for us, because one part of our education is completely focusing on the troubleshooting of different equipments, whatever respiratory equipments that we are using, whether it is nasal cannula, simple face mask, or a ventilator, or a non-invasive ventilator. We are troubleshooting all these devices. So you need to troubleshoot, but here it is a different equipment. Okay. The fundamental aspects of these respiratory care education make RTs uniquely qualified in undertaking the challenge of managing the ECMO. Okay. So in addition to all our formal training, we also have other capabilities of practicing in a multidisciplinary team, and different locations. You are there in the HDU, you are there in the ER, you are there in the transport team, you are there in the pediatric ICU, neonatal ICU, intermediate care units, you are there in the wards, you are also there in casualty and emergency surgical units. So you are there everywhere. So you know the circumstances, you know the atmosphere very well. You will be the one who is coping with this advanced treatment methodology very well. Finally, you definitely will have a question, how can I get certified? So I wanted to show you there are enough programs available. I want to appreciate IARC in collaboration with Narayan Hridayalaya last year organized a workshop. Many of our RT colleagues have got extensive training, and they undergone the training also in Narayan Hridayalaya. Their title is National Mechanical Ventilation and Hemodynamic and ECMO Workshop. It was, I think, all the week-long program. So the registration fees were very cheap. It was less than 2,500 or 3,000 rupees. Okay, in there, the most happiest thing why I'm encouraging you all to go there is that the target audience, and they mentioned, respiratory therapist as the fourth one, above even the perfusionists, because they don't have much idea about the ventilation perfusion strategies. Our ventilation perfusion strategies and the knowledge about this physiological changes and the effect on the respiratory system is very, very important in successfully managing a patient in ECMO. So you have a great opportunity. And again, if you want to go for a little higher level accreditation, there is, the health, I think Health Training Asia organization. They are offering an ELSO certified comprehensive adult ECMO course. It is purely online. The next course, according to their website, what is mentioned is 20th to 23rd of July 2020. And the problem is the fees. It is as valuable. If you think it is you need a hi-fi program, it is going to be costly. So it will be 100 times. Now the charge is like nearly 100,000 Indian rupees. And there are other ECMO training programs ongoing and happening in our country. It is in Mumbai. The upcoming program is from 4th to 7th of June. I don't know what is the schedule for now, but still you can get a lot of updates. You can do online programs, you can do on-site programs. I prefer you to go for on-site programs The other online programs are offering enough simulation sessions for the learning purpose, but it won't be enough for you to understand the real, the ambience of ECMO. Narayan Hrudayalaya is handling 200 cases, in a month. Not only in ECMO, it is a combination of ECMO and CPB. Sometimes it is arterial. So they have all this setup. All the full bed is occupied. I wish I wanted you all to go and experience this in this situation there, and get trained to face the challenges. And the recent publications came out. If you want to develop a ECMO program in COVID-19 situations, remember these key elements. Developing organizations that support the systems is the most important requirement. You need to have enough equipment, facilities, personnel, which is crucial to ensure optimal patient care, as well as the family and staff safety during the outbreaks of emerging infectious disease. They have given, this article has given extensive guidelines for how to arrange things for current pandemic. So I want all of you to go through this particular article. So in conclusion, the decision to initiate ECMO will always remain complex. There is no doubt about it. No clinical trial, however conclusive, can remove the role of clinical judgment in making the decisions about treatments. So with that I stop. I would like to show you a video